And today we're going to be doing alterations of the pulmonary function. So pulmonologist is the doctor that deals with the lung and the pulmonary circulation. Don't forget that your heart is so close to the lung. Now they're going to merge the two specialties together. So now we're going to have cardiopulmonologists. They're going to be working so together because they are so close physiologically, they are so close anatomically, and they are so close pathologically. Rarely will you have a patient who is suffering from a cardiac problem and their respiratory system is fine, or a patient who is suffering from emphysema, a problem in the lung, but somehow their heart and their circulatory system is fine. So they are so intimately tied that there are physiological connections between the respiratory and the cardiac and the circulatory system. There's anatomical correlate and anatomical correlation between both the respiratory and the circulatory system. And lastly, there is a lot of pathological correlation between both, as we will see. So if you look at your respiratory system is divided into two tracts, an upper respiratory tract and a lower respiratory tract. The upper respiratory tract begins with the oral cavity, and don't forget the nasal cavity, and then you have the trachea. So the oral cavity, you have the nasal cavity, the oral cavity, then you have the nasopharynx, followed by the oropharynx, followed by the laryngopharynx, and then we have the larynx, the voice box. That's the voice box, the larynx, and then you have the trachea. Below that begins your lower respiratory tract, and that begins with the, what comes after the trachea? Sorry? Esophagus. The esophagus is posterior to the trachea. So the epiglottis is the one that blocks the food from lodging into your trachea. What comes after the trachea? Yeah, very good. Don't be afraid. You're right. Try it. So that's you have the tertiary bronchioles. You have the secondary bronchioles, and you have the primary bronchioles, and lastly you have the alveoli, and those are the most significant structures of your respiratory system. So this division here, upper respiratory tract versus lower respiratory tract, what kind of classification, what kind of division is that? That's a structural classification. Are you on a second floor or a first floor? That's just a geographical. Where do you lay? Where is your apartment? Is your department on the second floor or the first floor? So that's just a structural. That's a structural. This is a structural classification. That is a structural or anatomical. That's a structural or anatomical classification. But when we look at the function, so now you see the school, you have the first floor is the administration, the executive cabinet, the president's office, and the provost, and the department chairs. And the second floor is actually the learning halls, the laboratories. So now that's a functional classification. So now it's not just about where are you exactly. So your respiratory system functionally, your respiratory system is divided into a conductive respiratory tract. You see, anatomically, structurally, it was upper respiratory tract, lower respiratory tract. But if you look at functionally, also known as physiologically, that's known as conductive. That is conductive tract. What does conductive mean? So everything in green is conductive. Everything in green is part of the conductive respiratory tract. Nasal cavity, oral cavity, nasopharynx, oropharynx, laryngopharynx, the larynx voice box, the trachea, the tertiary bronchiole, the secondary bronchiole, the primary bronchiole. All of that is just the conductor, meaning that it passes oxygen. It passes the air in one direction. It conducts it downward. It conducts the air in the down direction, or conduct it up, or conducts it upward, meaning you conduct it going up, down versus up. Now, you conduct down up to the primary bronchiole. This alveoli here, those alveolar sacs, this is the queen. Everybody's trying to pass the air to the alveoli. So this 90% of your respiratory tract is just conducting, is just passing it. It's like the airport. They just walk you through. They search your luggage, the TSA. You just go from one department in the airport to another until you get to the airplane. The alveoli is the airplane. That is known as the respiratory zone. Respiratory zone. Everything else is conductive zone. Everything else is conductive zone, except the alveoli or the respiratory zone, because they participate in the gaseous exchange. They participate in the gaseous exchange. So that's why if a patient has a problem in the nasal cavity, the oral cavity, the nasopharynx, oropharynx, laryngopharynx, larynx, trachea, any of the bronchioles, we can fix that. You can do a tracheostomy. You can do anything to repair if there's a problem somewhere in the upper or lower respiratory tract. Is that clear? But if you have a problem in the alveoli, can you repair that? You need a lung transplant. So the people now smoking a cigarette, that is very dangerous because the nicotine destroys the elastic recoil and the surfactant fluid that is on the surface of the alveoli. So now, the people who have emphysema, meaning that there's a defect in the alveoli, those people, they take a deep breath. Air is filling the lung, but is the alveoli able to take the air and pass it to the blood? No. So what happens to the alveoli? It cannot pass the air from the lung into the blood. So what happens to the overall oxygen saturation in the blood in that type of person? In somebody who has a lung fibrosis meaning alveoli are terminally damaged beyond salvage. There's damage beyond salvage. There's irreparable damage. What do you think happens? The overall level of oxygen saturation is going to drop. So what is going to be the reflex, the negative feedback, the repair of the problem? Well, your bone marrow is gonna, there's a lot of sensors, like tasting the blood, tasting the soup, tasting the blood is too acidic, the blood is too basic, there's acidosis, there's alkalosis, there's too much calcium, too little calcium. They taste chemical, too much carbon dioxide, too little carbon dioxide, too much oxygen, too little oxygen. Those receptors, those sensors, those detectors are called chemoreceptors. So when somebody who has lung fibrosis or emphysema, meaning that the alveoli are damaged, when they take a deep breath, the lung is full of air, but the air is not going in the blood. So now the blood oxygen level, the oxygen saturation is going to drop. And when the oxygen saturation is going to drop, what does the bone marrow do? The red bone marrow. Well, what does the red bone marrow do anyways? It produces red blood cells. When does it produce it? All the time? When what? When it's needed. So when will red blood cells be needed? When the oxygen saturation level goes down. You see, somebody who's drowning, they're drowning. When they do the autopsy, they find out that the bone marrow increased the rate of the erythrogenesis, the making of red blood cells. Because the red bone marrow has no way of knowing what's causing the oxygen to drop. All that it knows is that oxygen level goes down, let me make red blood cells. You go up in the mountain, you go to the top of the mountain. If you're up in the mountain, air, is the oxygen low in the top of the mountain or is the oxygen high at the top of the mountain? Mount Everest. It's very low, otherwise when you're in the airplane, there wouldn't be a compressor that releases oxygen for you. You just there'll be so much oxygen. No, oxygen is not oxygen, there's no oxygen in the mountain. So in the mountain, up in the hemisphere, if you go up in the elevation, oxygen drops. So your red bone marrow is going to start making more red blood cells. Now those people, they have emphysema because they're smoking, COPD. They take a deep breath, oxygen goes in the lung, but it's not going in the blood. Does the red bone marrow have any way of knowing that? So what's going to be the result of the people that have emphysema? They're gonna have a lot of extra red blood cells. So what will that do to the level of the viscosity and the thickness and the hypercoagulability of the blood? It's gonna be very thick blood like honey. Why? Because the red bone marrow doesn't know that we do have oxygen. It's just the alveoli are not working. So we make more red blood cells, more red blood cells, more red blood cells, more red blood cells, until the blood becomes so thick and there's blood clots. It's like deep vein thrombosis now. And that's also happens to people who are smokers, people who vape, smoke cigarette. The nicotine is going to lock the hemoglobin in a state known as the R state. R state, hemoglobin is going to lock the red, the red blood cell. The red blood cell has to be discoid and biconcave. Discoid and biconcave, meaning that it is doubly depressed. It's depressed from the top and depressed from the bottom. And is rich in hemoglobin. This hemoglobin now is a very big problem. If hemoglobin is unable to carry the oxygen, there's sensors. chemoreceptors detect that oxygen levels drop, then red bone marrow keeps making more and more. And you know, when they are rich in oxygen, they are in the R state. R state meaning you are rich in oxygen. The T state means that you unloaded the oxygen to the tissue, because hemoglobin is carrying the oxygen to the tissue compartment. It's carrying the oxygen to the tissue compartment. So now we see that smoking cigarette, smoking nicotine, smoking the vape is gonna lock oxygen in the R state. What does that mean? It means that my red blood cells are rich in oxygen. They just can never unload it to the tissue who needs it. Now, the red bone marrow doesn't know that it's going to make more red blood cells. That's why those little kids, little brats, the pediatrics, they take them to the clinic and they take their blood. They're 13, 14, 15, 16, and they have hypercoagulable blood. Why? Because they're smoking a cigarette in the toilet and they're vaping in the bathroom, and the mom, oh, not my child, no, yes, your child, because there's no reason why a 13-year-old little girl or a 14-year-old boy having your hypercoagulable blood. It's because of the nicotine being locking the hemoglobin in which state? R state. Rich in oxygen, just cannot deliver. You go to the bank, your money is there, you just cannot withdraw it. So that causes hypercoagulable blood, which makes it like deliver the blood to, which makes failure in the delivery of this blood, and causing blood clots and that. Yes.
You say that child
The most likely possibility, because that's the disease, the social epidemic that's happening now. The peer pressure. Now children no longer have control over their life decisions. They just have to get along. Imagine you're in this class. This class doesn't you're now adult. The class doesn't affect you. But if you're a little child, your personality hasn't developed yet, so you follow what people do. When I was younger, thank God I wasn't like that. The whole school went to prom. Guess who's the only one who didn't go to prom? Well, guess who's the only one who didn't go to the senior night and the party? Because that was just me. I didn't care about somebody. I had my own personality. I was trying to make sure people don't go to the prom. I told on my brother when he went to the prom. Yeah, I told my parents. But anyways, you have to have a personality. You have to raise your child to have a personality. Otherwise, their blood coagulation is going to go up. If you don't give a child a personality, they're going to be in a school. They're going to make their teachers are not good. Their friends are not good. Homeschool your child if you can. Like, you be the peer pressure. Like, you're they're not going to look at you like that. They're not going to look at you to, like, form their personality. They take their personality from the kids. They're not going to try to dress like you. You want to dress like your friend. So you put them in a good school where the friends dress good, so the kids dress good. But if you put them in a bad school, they're going to be smoking and vaping in the toilet, and that's very bad. Yeah, my children are not going to school here. Ha, ha, ha. Okay, I'm not dealing with none of that. They're going home. Yeah. My father wasn't in my life. Every man over there is your father. Okay, I send the money and I do what I can. You're not coming here. Okay, anyways. And when you go home, you take stuff from 99-cent store, they're so happy. But if they live here, they know, oh, that's 99-cent. That's not good. You got that from the Dollar Tree. But over there, they think it's from America. Yeah. Yeah. It don't matter how you teach anymore, because you're their peer pressure. So you can do your best. You talk, but it's really hard now. It's very bad now. The kids,
They are, some of them, they commit suicide because they don't want to do anything bad, but the peer pressure is too much. They have so much pressure. They don't want to do something, but they have to do it. And now some of them, they even commit suicide. So it's very, you know, school is not what people think it is. Anyways, we talked about the acute respiratory disorders. So now we already divided our respiratory tract conveniently into an upper respiratory tract and a lower respiratory tract. We begin with rhinitis. Itis, that is inflammation. So I get students confusing. Yeah, you need to know your hemoglobin and how it operates. I have students confusing how does hemoglobin. You know, last week I left my charger here with the charging thing and it's gone now.
Yeah, I saw it over there.
With the green belt.
Yes.
Where is it?
I don't know who took it up.
Oh, Stephanie, where did you put my charger?
I didn't touch it. We were asking, it was left in the wall. We were asking who it belonged to.
That was mine.
It wasn't in the box.
So what do we do now?
I don't really.
Okay, GoFundMe. Everybody put a quota for me. Okay, no. It's got to be somewhere. Lost and found?
It was in the wall.
Yeah, I'm gonna go.
It was.
I'm gonna go.
With two different people. Professor.
I did not put a marker on my brand new suit. No, I did not. I did not touch my brand new suit from Amazon with a marker. Oh no. I did not touch the suit that I bought for today's faculty meeting with a marker. No. Oh, this world is too much. Okay. All right. It's okay. No, actually, I did it. It looks like I did. My heart dropped. Okay. So, but yeah, actually, I need that thing. I need that charger. I hope they have phones that don't need to charge no more. I'll be happy. I have so many wires. I'm like the electrician. Okay. So, yeah. So now let's go over the problem that students have all the time, not knowing the difference between how hemoglobin works. How does hemoglobin operate? Okay, so you have your lung, and the lung is going to communicate to your, there's two trips. So now let's say that this is the tissue compartment. Tissue. Oops. So hemoglobin in the biconcave, discoid, bidepressed, double depressed, red blood cell. Going, it has a downtown trip. You know, every train has a downtown trip and it has a uptown trip. Downtown trip, uptown trip. So I have downtown and I have uptown trip. I have a downtown trip and I have an uptown trip. Okay, you know, the train, our train has an uptown.
our train has a downtown trip. Your hemoglobin, please listen to me before you answer. Look at the arrow. I'm leaving the lungs. I'm leaving the lungs and I'm going to the tissue. Please tell me, how is my oxygen and how is my carbon dioxide? And when I'm going up, I'm leaving the tissue. I'm going back to the lung. Somebody please tell me in this other trip. Well, first of all, let's agree to something. Do you think the levels of oxygen, carbon dioxide in a red blood cell going down and going up, will they be the same? They will not be the same because the target is different. Like when you go to a restaurant and when you're leaving the restaurant, are you the same person? No, you're going hungry, it's coming back full. If you're going from the lung to the tissue, the oxygen is high or low? Very high. It makes no sense that you're going to the tissue, but you have no oxygen on you. And it has low carbon dioxide. I'm not going to give my tissue poison. Carbon dioxide is toxic poison, acid. Okay, carbon dioxide is acid, toxic, poison, acid, toxic, poison. And going up, how is my oxygen level? Absolutely low, because my tissue is doing metabolism. Metabolism. The tissue is doing metabolism, burning all of the oxygen. So now I have low oxygen. What about my carbon dioxide? My carbon dioxide is, like Tim, carbon dioxide is very high. So now I know my carbon dioxide is synonymous. My carbon dioxide is synonymous with acidity, toxic, poison. So here, leaving the lung is like a purification center. And going to the lung, you're like low in oxygen and high in carbon dioxide. So if you look at acute respiratory disorders, there is rhinitis, sinusitis, influenza, and pneumonia. Those are acute respiratory disorders. We're going to talk about them in detail. Then there is asthma. Asthma is like a hypersensitivity. It's when your respiratory system goes into a state of overt defensive immune response to something that is not harmful. It's like Trump assuming that all foreigners are bad. You know, your immune system now, there is cancer cells, it will not have any reaction with the cancer cell, and it will go and fight the pollen, because pollen is a foreigner and a cancer cell look like, you know, a cancer cell is part of your own body. That's the problem. Not every foreigner is bad and not every citizen is good. So your own body, the immune system will leave the cancer cell and it will go and fight something that is not bad. Pollen. Some pollen is actually good. It has proteins in it and it has vitamins. So it helps you, but the immune system has no way of knowing that. So now there's an overt reaction. COPD, chronic obstructive pulmonary disease, and those are emphysema and chronic bronchitis. We'll talk more about them. We'll talk about tuberculosis, pulmonary embolism, and that when the blood clot lodges. My cousin died from that because she was pregnant. This happens in pregnancy because the mom circulatory system is accommodating two bloods, the blood of the mom and the blood of the baby. So the blood becomes hypercoagulable, which is an old problem as long as we get the RhoGAM shot. As long as we get the RhoGAM shot. This RhoGAM shot
is going to sensitize the mom from destroying her baby if the baby was Rh positive and the mom was Rh negative. Now, we need a shot called heparin. Why is heparin important? I'm sorry? It's a blood thinner because the mom's blood is hypercoagulable. So we need to thin it up and make it loose. Okay? And we add, make, and then there's pneumothorax, hemothorax, flail chest, where there's an injury to the integrity and the structure of the respiratory tract. And there's severe respiratory syndrome, SARS, we will talk about that. So we need to understand that respiratory diseases can have shared signs and symptoms. So for example, I'm in the emergency room. I see 5 people coughing. One is coughing because of asthma. One is coughing because of pneumonia, infection. One is coughing because of bronchitis. One is coughing because of emphysema. One is coughing because of some sort of embolism. There's different reasons, but the cough is one. That's why a cough is not a disease. A cough is a sign that you can see the person is coughing. There's a respiratory distress. So what is dyspnea? You're going to see it a lot. DYS. When you see DYS, that means excellent. Difficulty. DYS means difficulty. So there is difficulty in the breathing. Dyspnea is a form of a symptom where the patient is uncomfortable breathing. Orthopnea is when you have a difficulty breathing while you are laying down. That's a special and different type of sign and symptom. Are we clear? Okay, paroxysmal nocturnal dyspnea. You saw a keyword in there, nocturnal. That is when you wake up in the middle of the night, gasping for the air. Clubbing of the fingers is when the fingers bulge and you lose the angle between the nail beds. So if you see here, that's early clubbing, and you see the angle is being lost, that's moderate clubbing, and that's severe clubbing. That's a sign of emphysema. A friend of mine in high school, I met him one time, we shook hands. He was one of those smoking in the bathroom all the time. And high school was like, for me, 2006. So I met him in the hospital. I shook his hand. His nail looked like a dome. He had huge nails with dome because his lung, he now needs lung transplant, and he's so young. So younger people, you don't need to be younger or older people. Doesn't really matter. You don't need to destroy your body. You don't need to destroy your health. Now Trump is going to take away all of the insurance. Now no copay. Now you got to pay for everything now. Who's who? When you have emphysema, who are you going to go to now? This is the wrong time to be smoking now. Okay? It's always wrong, but now is the worst time. So be careful. Okay. So now acute respiratory disorders, rhinitis, sinusitis, and influenza or pneumonia. A nursing priority for clients who have acute respiratory disorders is to maintain a patent airway to promote oxygenation. So there's health promotion and disease prevention where there's hand hygiene, and we encourage immunization. Thank you. Limit exposure to airborne allergens, and promote smoking cessation. Yeah, we really need to know, we need to stop that. Back in the day, they used to have the thank you. You know, they say they have the light 100s, and is that still around? Light 100 is not there anymore. That's the old type of thing. So they used to trick the people, say, you know, light 100 is better than that. Is not. They're all as bad. I remember my dad used to work in a gas station, so sometimes we used to go to work with him and help him. There were so many different varieties of cigarettes and cigar, and we were in the counter with dad, and so many different colors of cigars and cigarettes, so many different colors, so many different marketing, and people coming in, give me Newport, give me the Coles, Marlboro, give me this, give me that. I said to her, oh my God, I need a cigarette. Because I'm in there all the time and I'm watching people buying them. And you know, you're young. So these big guys coming in buying cigarettes, I want to be just like that. And that is very bad. You know, thank God, you know, he don't work there no more. But it's just bad the way how they market something terrible. Like the box looks so nice. And you know, the photo of the one smoking it is like a handsome guy and with like a girl. So that means if you're smoking, you're gonna get a girlfriend. Oh, this world is a sick place. Rhinitis. So itis is inflammation. So rhinitis is an inflammation of the nasal mucosa. So you know, remember we said earlier that your nares, they are the entry site. Remember, conductive. So you enter the airport and you go through different departments in the airport till you get to the airplane, the alveoli, so you can fly into the bloodstream. When the air comes in, it makes no sense that air goes in. We need, you know the mouse trap with glue? There is glue. Your mucosa is glue, but not to trap the mouse. No mouse is trying to get in your nose, at least for now. But there's a lot of bacteria. You know, the air is polluted. We're not in heaven. We're not in the womb. You know, the baby is in the womb. When the baby is born, is always sick because when the baby was in the womb, it was sterile. The blood compartment is sterile. Not a single one bacteria. Not a single one bacteria within there. Now he's dealing with all of the bacteria and the viruses. That's why the baby is always sick, but the sickness makes you strong. I had a student today in my advising session. She cried. I told her, I'm sorry to see you crying, but I know those tears are changing you, making you stronger and giving you wisdom. The work was too much for her, but she's getting better. And then she's gonna get better. I know. But she was happy when she left. When she left, she changed. Like I was able to change her mood. She was happy. She told me she want to take my class next semester. But that's how it is. You don't want to fail the NCLEX. We don't want students in our school failing the NCLEX, and it's not going to be easy. So you're going to study a lot, do a lot of questions. The questions are like pinpointers. The question with the answer is going to pinpoint you because I can talk forever. The information is not going to stick unless you do the question. So do the questions and review. Rhinitis is when that glue, that mucosa layer becomes inflamed because it's going to trap. And you know there are resident and sentinel macrophages in the mucosa. To trap is like police precinct, but they're white blood cell precincts. To trap any microbe that are, you know, the air is full of microbes, and especially the air of the industrial urban societies. And if you go back home, like in the village where there is a lot of trees and the nature, is good. But you walk in here, it's very bad, the fume and the gases and the cars. You know, there is a high rate, you know, the pulmonologists make a lot of money in New York City because the people always in the subway, and it's very unhealthy to live in New York City. It's going to cost you your health. Coryza is common cold. It's caused by a virus that spread from one person to another person. And droplets from the sneezing or the coughing or direct contact. We're going to need hand sanitizer in every single 1 foot, every 1 foot in New York City, there should be like a hand sanitizer because it's really out of control. And rhinitis is with nasal drainage. You know the fluticasone propionate? That's amazing. Sprayed in the nose. Yeah, it's on the spot. It's like my grandma said, it's like cement. My grandmother said that she used to have runny nose, so I gave it to her. She came from back home from my country. She never wanted to take it. She said she is not a drug addict. I told her no, just sniff it, and so we convinced her. So she took really big puffs, and then she was like, "It's like cement." She said nothing. My grandmother is hilarious. Yeah, I sent her a video of me wearing a clown with red nose and playing with my nephew's kids. She said, "I love that, but I want you doing that with your own kids." I told her I'm not having kids until I'm 50. She said I'm not going to be around for that long. So I told her, I'm sorry, I got to do my PhD. Abdullah, we got to do our PhDs. Yeah, I have I need 10 more years before I get bound into somebody.
So you don't have kids?
I don't have kids. Yeah.
I thought you had kids back home.
I had kids back home. It's like an imagination. Yeah. Oh, I said, yeah. I said in the future, they're not gonna be here. Even back home is bad too. This world is ending. Back home is also bad. Yeah, back home is bad too. Yeah, I don't know where to go now. I'm going to another planet. Sinusitis. Oh, you need to know the sinusitis. What are sinusitis? Sinusites are the fluid-filled sacs. You know the air, before it goes in your respiratory tract, the air is too cold. It can't go inside your trachea. It's going to make you sick. So it goes in those sinusoids and flip and rotate in there and get warmed and humidified. Then it can go into your trachea. That's the importance of the sinuses. Why do we have sinuses? So to humidify, warm, like the oven to warm up the air. It's too cold, this air out here for the lung. And it's, the fluid-filled sacs, they have a lot of mucus. So that gets inflamed also. Then you have sinusitis. Okay, expected findings. So you have nasal congestion, headache, facial or pressure pain, medications or nasal decongestants, broad spectrum antibiotics. Yeah, the runny nose is bad, especially if you lecture. That's very bad. I had it in the beginning of the winter. Yeah, I don't cover my nose, so the air goes in the nose, and I felt like there's burning fire coming down my nose. And then I called out of work, and they yelled at me because you don't cover your nose. I can't cover my nose. I need to breathe. I'd rather breathe cold air than have a thing. Anyways, influenza. So with influenza, you would have headache, muscle ache, chills, fatigue and weakness. And sometimes influenza can lead to diarrhea in some people. And the fever is when the thermostat is reset and there is really high, the temperature goes up, and the fever is actually burning and killing all the bacteria. You know how to get rid of fever? Turn on a cold shower, and the longer you stay in the cold shower, the faster the fever is going to go away. Try it. One day you have a fever, just go in a shower, turn on a cold shower, and just jump in and try. Be patient. It'll take the fever right out. Fever is like, like the hell, like the devil. If you put cold water, it's going to go away. Try that once. Have you tried taking a cold shower when you have a fever? Yeah. I was energetic. Like when I took the cold water, it just make me, and people don't take the cold pad. You have to be very careful. You see, people cannot wait to go and take an antipyretic. If a little child is sick, they can't wait to give them the Tylenol. And what's the other one besides Tylenol? Ibuprofen. To bring down the term fever. But if you take it, it's going to stop the further development of the fever. But the old fever that was already there, is it going to go away? No, is the water pad is going to make the heat flow from an area of a high heat, high thermal gradient to a low thermal gradient, and it's going to suck it out. That's why children have febrile fevers, ending up with seizure, because the heat now spread into the brain, causing to influence the balance centers, which cause that form of shock. Now we're going to infections. So pneumonia, there's two types. There's community-acquired pneumonia, known as CAP, and there's healthcare-associated pneumonia, known as HAP, H-A-P. Let's begin with CAP, CAP. Community-acquired pneumonia is the most common type, and it often occurs after being preceded with influenza. So a patient that had influenza and then they had pneumonia, it's community acquired. Healthcare, it has a very high mortality rate and more likely to be resistant to antibiotics. It takes about 24 to 48 hours from the time the client is exposed to the healthcare associated pneumonia. You have to know that these nosocomial infections, nosocomial infections are a big problem, because in the hospital, when they're using the antiseptics and the detergents to kill the bacteria, they kill about 99%. 1% remains. In no time, that 1% who remain is going to become 100%. If you use the old type of bactericidal, is it going to kill it now? No, because they survived it in the first place. So we're always in a fight with developing new microbicidals to kill new bacterial variants that kept on surviving mutation. Always. And you kill 99% and then 1% remains. Look at COVID. Many people died, but we lived because you had strong genes. Another disease, who knows, in 5 years may come. Who knows is going to make it through. So always the survival is for the fittest. If you're fittest, then you're going to be able to survive. If you're not fit, then you're going to die. So the bacteria survive this wave of microbicidal hospital detergent. So if you get sick of a disease that's all in the hospital, very hard for you to be treated. Are we clear? Questions? Older adults are more susceptible to infections due to decreased pulmonary reserve, that is age-related lung changes, and a decrease in lung elasticity, or the thickening of the alveoli. Expected findings are people who have pneumonia always have anxiety and fatigue and weakness. There's chest discomfort due to the coughing. There's confusion from the hypoxia. That's the most common in the elderly people. The physical assessment is fever, chill, flushed face, diaphoresis, shortness of breath, difficulty breathing, tachypnea, pleuritic chest pain, sputum production, crackles, and wheezes. Those are all the different measurements that we use to assess pneumonia. Now in the lab, to completely diagnose pneumonia, we rely on sputum culture and the sensitivity, and we look at the CBC count. So there's usually elevated white blood cell count, and we look for acute blood gases. So here you have hypoxemia, where the partial pressure of oxygen is going to be less than 80 millimeters of mercury. So blood culture is to rule out the organisms in the blood, and electrolytes we use the electrolytes to identify any form of dehydration. Diagnostic procedure is we do a chest x-ray and we look for consolidation of the lung, and that may appear later, and It's going to be vague in the elderly people. We perform pulse oximetry to find out the saturation level of oxygen. Okay. The treatment or antibiotics, since we're dealing with the bacterial infection, we use bronchodilators because once you increase the diameter of the airway, we're accommodating more air and anti-inflammatories. Complications are atelectasis, which is the collapse of some part of the lung, bacteremia, also known as sepsis. What is septic shock? This is very important. Now, you need to know something that is very important when it comes to shock. Hmm? Okay. You need to know that the cardiac output, CO, cardiac output must equal stroke volume, meaning how much blood is coming out of the ventricles multiplied by stroke volume multiplied by TPR. What is TPR? TPR is total peripheral resistance. Now, what's happening here? My cardiac output. What is my cardiac output? How much blood is being ejected into the aorta, going out in the tissue compartment. If we now look at the stroke volume, that is how much blood is being, the volume of the blood that is being ejected from the heart, ready to go to the tissue to deliver the oxygen. The total peripheral resistance is the impediment and the challenge that the stroke volume is facing in its way to get to the tissue. The blood is trying to get to the tissue to provide the tissue with oxygen for oxidative phosphorylation, to provide the tissue with oxygen for aerobic respiration, to provide the tissue with nutrients, to provide the tissue with all of the supplies for survival, and also to remove metabolic waste. Now, if the blood is flowing in this blood vessel like that for person number one, and person number two has a blood vessel that looks like this. What's this bulge here? That's atherosclerosis. That's atherosclerosis. So the blood is not passing through. The blood is not passing through. Why? Because of the bulge is making a resistance. So one of the causes of resistance is the hypercoagulability of the blood. If the blood is too thick like honey, it's going to have resistance. It's not going to be able to move smoothly. But if the blood is so thin, it's going to move fast. Also, the presence like of cholesterol, that increases resistance. So atherosclerosis increases TPR, total peripheral resistance. In addition to that, we know that total peripheral resistance is affected by the atherosclerosis and it's affected by the viscosity of the blood.
by the viscosity of the blood. Blood is too thick. Hypercoagulability. 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 That's going to increase the resistance. You guys agree with me? Now, if the blood is thin, it's not going to affect the total peripheral resistance. If there is no atherosclerosis, no total peripheral resistance increase. What about the diameter? This is person number 1, and this is person number 3. Look at the diameter of this blood vessel here, 1, and the diameter of this blood vessel here. Which diameter is bigger? Which diameter is bigger? The second one. So that means the total peripheral resistance is higher where the diameter is bigger or when it is smaller. If the total peripheral resistance is evaluated for both blood vessels, this one with this diameter and this one with this diameter, where is the total peripheral resistance higher? Is it higher for 2 or is it higher for 1? Raise your hand if you think the total peripheral resistance is higher for 2. Raise your hand if you think the resistance is higher for 1. Absolutely. The blood is going to have a difficulty going through a tight, really tight blood vessel compared to a wide one. So that's why now people have high blood pressure. Do we give them medication that will vasodilate, make the blood vessel wide, or we give them medication that will make the blood vessel tight? Right. Make it wide. So now the pressure, because the pressure goes high with resistance. If the resistance goes high, the pressure goes high with it. If the resistance drops, the pressure is going to drop. So now you see, this is a very big problem that we see the total peripheral resistance is inversely proportional to the radius or the diameter. Now, if I am looking into we're talking about shock. So what happens in shock? Let's say I have pneumonia for 1 day, no, 2 days, no, 3 days. Now is a week, 10 days, 15 days. Why is that a big problem for your circulatory system? You know your circulatory system is like your highway. If there's a crime somewhere, the police are the white blood cells. The white blood cells are the police. The white blood cells are the police. And the blood vessel is the highway. If there is an area with high crime, you're going to see the police running there. So that's why, do you think it's in your best interest when you have pneumonia for your blood vessels to be wide or to be tight? To be very wide, because you have bacteria inside your body. You want to deliver as many white blood cells as possible, right? So what do? We vasodilate. Are we clear? To vasodilate. What did we say the vasodilation does though, as a side effect to the total peripheral resistance? What does it do, the vasodilation do? It's going to decrease it. And if the total peripheral resistance decrease, what happens to the cardiac output? Increase. Regina said increase. Regina said decrease. Yes, because if the total peripheral resistance decrease, the cardiac output is gonna decrease. So when your blood vessels are dilated for a week, 10 days, 15, 17 days, your blood cardiac output is gonna drop, and that's called septic shock. So shock is the same. Shock is when the blood pressure plummets, drop, and you die. But the reasons are different. We have cardiogenic shock when the heart muscle is not contracting enough, so not enough blood coming out. Shock or maybe there's anaphylactic shock, which is very similar to septic shock. The only difference is septic shock, you have actual microbes that elicit the vasodilation of blood vessels, and that increases the diameter, drops the resistance, and then drop the cardiac output. And anaphylactic shock is pollen. The same response, your body thinks that pollen is an enemy, so now it mounts a lot of white blood cells and antibodies to go attack it. And that prolonged vasodilation leads to a drop in blood pressure. There is neurogenic shock. What is neurogenic shock? Neurogenic shock is if you, God forbid, get hit by a car, and you get hit by a car in your, and then the back is that you have a damage, defect in your back, and then the spinal cord regulates the diameter, so now it's damaged. Now they're overtly dilated for too long. Then you have shock. That's called neurogenic shock. Hypovolemic shock, a stab wound, gunshot wound, dehydration, you lose blood, that's going to lead to shock. You need to know how your microbes can lead to septic shock. Okay. Now we're going to go into asthma. We discussed asthma. Asthma is a chronic inflammation of the airways. It caused by bronchial hyperresponsiveness. We mentioned that. There's pollen, and your body is like Trump. It thinks that every foreigner is bad. So pollen is a foreigner, but it's not bad. It's actually good. Some foreigners, illegal immigrants, they come here to work. They're coming here to feed their families and to do jobs that your typical citizen will not do. And you have citizens here who are out to do robbery and crime and kill. So you should look into who is who before you just generalize that all foreigners are bad. So the immune system now assumes that pollen is bad, and then it mounts a response. Sometimes pet dander, sand, you get that type of reaction to it. Okay. So asthma causes mucosal edema, bronchoconstriction, and excessive mucus production. There are 4 categories of asthma. There is mild intermittent, where the symptoms occur less than twice a week. Mild persistent, symptoms arise more than twice a week, but not daily. Moderate persistent, daily symptoms occur in conjunction with exacerbations twice a week. And severe persistent, where symptoms occur continually along with frequent exacerbations. What are the risk factors for asthma? Number 1, asthma is genetic too, because remember, your immune system is the one behind it. Your immune system is the cause of it. So the genetics play a big factor in how your immune system operates. So family history, always the adults, the capacity of the immune system drops, so it no longer can tell self from non-self as good as it used to. Smoking and secondhand smoke exposure, environmental allergies, exposure to chemical irritants or dust, and GERD. GERD is gastroesophageal reflux disease. Asthma is always accompanied with dyspnea, chest tightness, anxiety, or stress. Physical assessment findings are coughing, wheezing, mucus production, and there's a use of accessory muscles and prolonged exhalation. There's a barrel chest or increased chest diameter. Laboratory tests are hypoxemia.
What's the
Hypocarbia. When there is a carbia, is carbon dioxide. Hypocarbia meaning the carbon dioxide is down. So when the partial pressure, hypercarbia is when the partial pressure in arterial blood gases is more than 45 millimeters of mercury. Hypocarbia is when the partial pressure is less than 35 millimeters of mercury. Hypoxemia is when the oxygen saturation is less than 80 millimeters of mercury. That's hypoxemia. Sputum culture is when the bacteria can indicate the infection. So diagnostic procedure or pulmonary function test where the forced vital capacity and the forced expiratory volume in the first second are evaluated, and then we examine the chest x-ray. Medications, you have the short-acting beta-2 agonist, and those are the albuterol as a rapid relief of acute asthma, prevent exercise-induced asthma, and adverse effects are tremor, and tachycardia. Tremor and tachycardia. Anticholinergic. We have the ipratropium. Those are parasympatholytics, and they are responsible for bronchodilation because asthma is there's a spasm, there's a constriction, overt tightness, so the air is not flowing properly into the airways. Methylxanthines. You have theophylline only when other treatments are ineffective. There's long-acting beta-2 agonist. That's the salmeterol. It is used for asthma attack prevention. Anti-inflammatory agents. Those are the corticosteroids. There's the fluticasone and the prednisone. We also use leukotriene antagonists. These are the montelukast. And those, they suppress the degranulation. They suppress the degranulation of the mast cells. So when mast cells degranulate, they elicit and trigger this vasospasm of the airways. Mast cell stabilizer, that's what we just talked about, to stabilize them, prevent them from degranulation, and those are the cromolyn. Monoclonal antibodies. You have the omalizumab. These are important anti-inflammatory agents. Combined agents are bronchodilator and anti-inflammatory agents. If prescribed separately for inhalation administration, at the same time, administer the bronchodilator first in order to increase the absorption of the anti-inflammatory agents. Ipratropium and albuterol, or the fluticasone and the salmeterol. You have corticosteroid, fluticasone, prednisone, leukotriene antagonist, montelukast, mast cell stabilizers, and the cromolyn. Combined agents, bronchodilator and anti-inflammatory agents. If prescribed separately for the inhalation administration at the same time, you have to administer the bronchodilator first in order to increase the absorption of the anti-inflammatory agents. Ipratropium and albuterol or fluticasone and the salmeterol. These are the combinations. Okay. Now we move into chronic obstructive pulmonary diseases. So chronic obstructive pulmonary disease is characterized by persistent airflow limitation. We discussed that earlier. There is a problem in the alveoli. So it's usually progressive, meaning that it gets worse with time. It exacerbates. It is the most common lung disease in the world, and the risk factors are always tobacco smoke or occupational dust and the chemicals, air pollution, and any factor affecting the lung growth and the duration of the gestation and the childhood. COPD encompasses two diseases, emphysema and chronic bronchitis. So now we're going to go over the criteria to how to differentiate between both. Most patients who have emphysema also have chronic bronchitis. So COPD is irreversible. You cannot go back to it. You cannot repair it like it used to, but you can stabilize it. So most patients who have emphysema, they also have chronic bronchitis, and that typically affect middle-aged to older adults. Emphysema is when there is a loss of lung elasticity. Remember we said that the alveoli are like bubbles, like balloons, and they recoil after being stretched and full of air. So there is a loss of lung elasticity and there's hyperinflation, meaning patients who have emphysema, once they take a deep breath, air goes in, but it can never come out. So that's the problem. So there is a stretch, but no recoil. Tissue causing the destruction of the alveoli, leading to a decreased surface area for gas exchange, carbon dioxide retention, and respiratory acidosis. Inherited deficit of alpha-1 antitrypsin. So the alpha-1 antitrypsin, there is an enzyme called trypsin. Trypsin is bad. Trypsin is gonna degrade and chop up and destroy the elastic surface of your alveoli. But this factor here, alpha-1 antitrypsin, is anti. So it's anti the bad guy. It's anti the trypsin. But some people have a mutation. They have a genetic disease where there is alpha-1 antitrypsin, is anti to this trypsin. And there's a air trapping. There's an air trapping. Chronic bronchitis. There's inflammation of the bronchi and bronchioles due to chronic exposure of the irritants. There's hypersecretion of mucus and chronic productive cough that lasts for at least 3 months of the year. So this is the criteria to distinguish between chronic bronchitis and emphysema. There's a hypersecretion of the mucus, and there is a chronic productive cough lasting for at least 3 months of the year for at least 2 consecutive years. So for the patient has to report within the past 2 years, not more than that, that patient had a productive cough with mucus for more than 2 months. Does inspire irritants increase the mucus production and the size of the number of the mucus glands? The mucus is thicker than normal. So we talked about the tobacco smoke, air pollution is going to lead to the inflammation of the airway epithelium. And we said this inherited defect, where there's an alpha-1 antitrypsin deficiency, is going to lead to inhibition of the endogenous antiproteases. Remember, the protease is the enzyme that destroys the elastic recoil of the alveoli. So we need antitrypsin, antiproteases. So if you look now, in chronic obstructive pulmonary disease, we said that air goes in, but due to the bronchial wall collapse, the air cannot come out. And this yellow here is a mucus plug that is gonna further cause resistance and prevent the release of the air from the alveoli. So the air doesn't, it comes out, but a little bit. It doesn't stay, that's why they are alive, but not enough. Yeah, they take a deep breath, the air comes in, but when they want to go out, not as much come out. So they're always retaining too much what? Carbon dioxide. Carbon dioxide, and now they cannot get it out. So there are a lot of carbon dioxide build up, which causes what? If you have too much carbon dioxide in blood, what does that lead to? Acidosis or acidemia. Very good. So when it comes to the health promotion and disease prevention, we have to promote a style of the cessation of smoking. Okay, and we must use protective equipment at work like masks when indicated, and we have to have environments that contain carcinogens or particles in the air, and influenza and pneumonia immunizations are important for all clients with COPD, especially for older adults. Risk factors, we have advanced age, and cigarette smoking is the primary risk factor. There's alpha-1 antitrypsin deficiency, and there's exposure to the environmental factors, the air pollution. Physical findings for chronic obstructive pulmonary disease. You have dyspnea upon exertion. Productive cough, hypoxemia. What's the difference between hypoxia and hypoxemia? Both of them are drop in oxygen. Hypoxia or hypoxemia. Both of them represent drop in oxygen. Absolutely, very good. One is in the blood, one is in the tissue. Which one in the blood, which one in the tissue? Hypoxia is in the tissue, hypoxemia is in the blood. Very good. There is a distinctive barrel chest sign that we can all detect on the clinical examination, and that indicates there is emphysema. Hyperresonance, when there's performing percussion, that leads to emphysema. And pallor and cyanosis. Laboratory tests, when there's an increased hematocrit level due to low oxygenation levels, and the use of sputum cultures and white blood cell count to diagnose acute respiratory infection. There is arterial blood gases, ABGs, and there is hypoxemia. So in hypoxemia, there is a decrease in a partial pressure of oxygen. In hypercarbia, there is increase in carbon dioxide. We talked about that. In hypercarbia is when the increase in the partial pressure of carbon dioxide being more than 45 millimeters of mercury. That's too much. That's poisonous. In hypoxemia, there's a decrease in oxygen less than 80 millimeters of mercury. In a diagnostic procedure, we have the forced expiratory volume, FEV, to forced vital capacity is used to classify COPD as mild to severe. As COPD advances, the FEV to FVC ratio is going to decrease, and there is a drop of about 70% mild COPD and less than 50% moderate to severe. Okay, chronic obstructive pulmonary disease. There is short-acting beta-2 agonist known as albuterol, cholinergic antagonist, ipratropium. There is a block of parasympathetic causing bronchodilation and a decrease in pulmonary secretion. And we also use the methylxanthines. Those are theophylline, where it's used only when other treatments are ineffective. So there is chest physiotherapy. That's for therapeutic procedures. And also raising the foot of the bed slightly higher than the head is going to facilitate optimal drainage and the removal of secretions by utilizing gravity. Humidifiers are useful for dry climate or in dry heating during the winter times. Tuberculosis is an infection by a gram-positive bacteria known as Mycobacterium tuberculosis. It is the leading cause of death from a curable infection disease in the world. So there is different types of modalities for the transmission of tuberculosis. There is airborne transmission, like aerosolization. So once inside the lung, the body encases the tuberculosis bacillus with collagen and other cells, and this can appear as a round nodule or a tubercle on the chest x-ray. There's only a small percentage of people infected with tuberculosis, and they actually develop an active form of the infection. Their primary effects, it primarily affects the lungs, but it can spread through the blood to the bone, the skin, or the other organs. We should be screened for tuberculosis if we have a client who lives in a high-risk areas or family members of the clients who have the tuberculosis, so they are in close contact with this patient, and people who are born outside the U.S. and migrant workers, because as we know that tuberculosis is widely spread in infectious regions around the world. So if you look into the first world countries in Europe and in North America, the leading cause of death is usually cancer because of terrible lifestyle, alcoholic consumption, and the terrible dietary choices. But if you go to, for example, in Africa, you see that Africa or South Asia or Latin America, countries that are considered third world countries or developing countries or underdeveloped countries, see the main leading cause of death is the infectious diseases, because it's very expensive and very hard to have a clean and a sanitary environment. It's very expensive to have all of these detergents and the cleaning supplies. So there's a lot of microbial infections, and that's why the leading cause of death is going to be these preventable infections. Okay. Expected findings in tuberculosis are persistent cough that lasts longer than 3 weeks. The sputum is purulent, and there's a possible blood streak. There's fatigue and lethargy, and there's weight loss and anorexia, and there is night sweats and low-grade fever in the afternoon. Lab tests are nucleic acid amplification testing that detects the presence of Mycobacterium tuberculosis in the respiratory secretion. We also look for the gold quantiferon tuberculosis gold. It's a blood test that detects interferon gamma in the fresh heparinized whole blood, diagnosing the active or latent, and the results are available within 24 hours. Acid fast bacilli smear and culture. These are a positive acid fast test that suggests an active infection. The MAN2 test, that's an intradermal tuberculosis test. It may be positive within 2 to 10 weeks. And this is a positive skin test is known by you examine and you find there's an induration, a palpable induration. There's a raised hardened area of 10 millimeters or more in diameter. The induration of 5 millimeters is considered positive test for these immunocompromised. So usually for healthy normal people, 10 millimeters are about the diagnosis for tuberculosis. But if you have an immunocompromised patient, then it takes much less than that to be diagnosed, and it drops from 10 into 5. Okay. For the therapy, we rely on the isoniazid therapy, and here we use isoniazid quad. This is the quadruple typical 4 medication regimen. That is the isoniazid, rifampin, pyrazinamide, and ethambutol. That is taken for 6 to 10 months. Multi-drug resistant tuberculosis could take up to 2 years. And we need to know about the miliary tuberculosis. That's when the organism invades the bloodstream and now can utilize the blood circulation to spread to multiple body organs with complications. Pulmonary embolism, we discussed that when we talked about deep vein thrombosis. When there's hypercoagulable blood, there's occlusion of a portion of the pulmonary vasculature by an embolism that enters the venous circulation. Pulmonary emboli commonly arise from deep veins in the lower leg. That's known as venous thromboembolism. That is the most common cause, deep vein thrombosis. There are other types of emboli. You have fat, air, and septic emboli. That is due to the bacterial invasion of a thrombus. You have a thrombus. A thrombus is a blood clot. We use streptokinase to dissolve apart this thrombus clot. If this thrombus stays for too long, you can have a bacterial infection superimposed in that clot, and it's going to migrate with the clot. So that could be a septic embolism. Pulmonary embolism is a medical emergency, and we need to prevent the deep vein thrombosis by doing leg exercises. You see people who run a lot, their blood circulation is running at a high pace, so that prevents the formation of clots. Compared to people who are sedentary, they're laying down all the time, the blood circulation is not moving as rapidly, so they tend to form a lot of thrombus and a lot of blood clots. Okay, we discussed the pulmonary embolism. How do we detect the pulmonary embolism? By the arterial blood gas analysis, and we find that the partial pressure of carbon dioxide is low, normally between 35 to 45 millimeters of mercury, due to the initial hyperventilation. And we perform not a X-ray, but a computed tomography scan. So there's a multi-detection of the CT scan. This is the MDCTA, is a special type of diagnostic and is used as a standard criterion for pulmonary embolism. Okay, anticoagulants are used, as we mentioned, the streptokinase to break apart this coagulation. And there is a direct thrombin inhibitor known as dabigatran, and that is a direct inhibitor of thrombin. We said that the alteplase, and we can also perform embolectomy, which is a surgical removal of the embolus. So you see ventilation perfusion abnormality. That's when the alveoli is ventilated, but the oxygen is not being shifted from alveoli into the blood circulation. Okay. Pneumothorax is when there's a trauma. So the presence of air or gas where it doesn't belong. The presence of air or gas in the pleural space, the pleural sac that surrounds the lung. So your lung is, let's imagine that you have a balloon and the balloon is full of water. If you press on the balloon, you have your fist inside the balloon, and now the balloon is surrounding your fist
from all around it. Your lung, and not only the lung and the heart and the abdomen are all surrounded with a protective capsule, balloon. That capsule is full of serous fluid. Can that serous fluid become contaminated with bacteria at some point? Yes. Absolutely. So if it gets contaminated, if the bag around the heart gets contaminated, that is known as pericarditis. Yeah. If the lung, the fluid around the lung gets poisoned with this contaminant microbe, this is known as pleuritis, because it's an infection of the serous fluid in the balloon around the lung, not the lung itself. Now you can have a puncture in the balloon. So now the air is going to flow from the area of high concentration to an area of a low oxygen concentration from the lung into the balloon, into this surrounding fluid. So you have spontaneous pneumothorax. It occurs when there has been no trauma or there's a small bleb on the lung that ruptures and air enters the pleural space, and there's a hemothorax. In hemothorax, there's accumulation of blood in the pleural space. Risk factors. When there's blunt chest trauma or penetrating chest wounds, if there's anxiety, so also you see that people who have pneumothorax or hemothorax. Pneumothorax, what's the difference between pneumothorax and a hemothorax? Yeah.
One is air, another is blood.
Absolutely. Pneumothorax is when air flows into the pleural cavity due to a trauma or a puncture. Hemothorax is when now you have a blood and a hemorrhage. There's an internal hemorrhage that goes inside the pleural. Okay. So the routine test as for pneumonia and all of the infectious diseases, the arterial blood gases have hypoxemia, where there's a partial pressure of oxygen that is less than 80 millimeters of mercury. So if the arterial blood gases have a partial pressure of oxygen that is less than 80 millimeters of mercury, that is known as hypoxemia. We use x-rays used to confirm the pneumothorax and the hemothorax. There is thoracentesis, so you have surgical perforation of the chest wall and the pleural space with a large bore needle. Flail chest. So it occurs when at least two neighboring ribs, usually on one side of the chest, sustainable multiple fractures causing instability of the chest wall and paradoxical chest wall movement. So this results in significant limitation in the chest wall expansion. The free-floating rib segment causes the lung below the flail segment caves in on the inhalation and balloons out on the exhalation. So the portion of the lung below the flail segment cannot participate in gas exchange, so oxygenation is going to be compromised. So we have flail chest, we have blunt trauma where there's motor vehicle crash, cardiopulmonary resuscitation, and there's unequal chest expansion. Okay. As a nurse, the responsibility is to administer humidified air because the conducting zone is not performing at optimal capacity. We monitor the vital signs and the saturation of the oxygen, and pulmonary function test. There's periodic chest x-ray and arterial blood gases. And here you see that's the flail chest, and you see that there's failure in maintaining the proper structural integrity of the lung, and that interferes with the gradient of the oxygen, and air is not moving correctly in the direction from the lung into the blood. There is a disturbance due to the disturbance in the structural integrity of the chest. Okay.
Respiratory failure. So we have acute respiratory failure, acute respiratory distress syndrome, and also there is a infection known as severe acute respiratory syndrome. So we begin with respiratory failure, which is acute respiratory failure known as ARF. That is caused by failure to adequately ventilate or oxygenate. So we do have the air. We began the lecture with this concept that oxygen is there. We just cannot deliver it and bring it into the blood. So there's a ventilatory failure, and there's a mechanically abnormal diaphragm or malfunctioning respiratory control in the brain. There's oxygenation failure that results from lack of perfusion to the pulmonary capillary bed. There's both inadequate ventilation and oxygenation, and the criteria for the acute respiratory failure are based on arterial blood gas values. Ventilatory failure, you have COPD and pulmonary embolism. And there we have the pneumothorax, so known as the flail chest. And there's oxygenation failure. So you have pneumonia, hypoventilation, hypovolemic shock, pulmonary edema. Sometimes there's a combined ventilatory and oxygen failure. So that's the worst prognosis if a patient has both, has combined ventilatory and oxygen failures. And you have hypoventilation and chronic bronchitis, emphysema, and cardiac failure. Acute respiratory distress syndrome. So you have a state of acute respiratory failure with a mortality as high as 58%. Risk factors, you have localized lung damage, shock, disseminated intravascular coagulation, and that is when the blood vessels are coagulating at known centers and the coagulation is not distributed uniformly throughout the body. So you have regions in the vasculature where you have blood vessels with concentrated blood clots, and now the blood is too loose in one region of the body and too clotted in other regions of the body. So that is known as disseminated intravascular coagulation, which is a sign of respiratory distress. Okay, respiratory failure, severe acute respiratory syndrome, that's the result of a viral infection. That's why they classified, SARS back in the day. It was something like the COVID. And from a mutated strain of the coronaviruses, which is a group of viruses that also cause the common cold. Virus that invades the pulmonary tissue, which leads to an inflammatory response. And you have a virus that is spread easily through the airborne droplets. The virus does not spread to the bloodstream due to it flourishes at temperature slightly below the normal. Expected findings are would have dyspnea with or without excretion, with or without exertion, orthopnea, meaning that difficulty breathing while laying down, rapid shallow breathing, and there's cyanosis. Cyanosis is a sign, meaning that there's a bluish pathological discoloration of the skin, meaning that there is hypoxia, drop in oxygen concentration. Laboratory test, you have arterial blood gases to confirm and monitor acute respiratory failure. You perform chest x-ray, and the most important thing, as I mentioned to you, the respiratory system does not work in isolation from the cardiac and the cardiopulmonary system. So that's why we perform an EKG for a patient suffering from a pulmonary disease. That is how close anatomically, physiologically, and pathologically the respiratory and the circulatory system are. Medications for respiratory failure are the benzodiazepines and lorazepam and midazolam to reduce anxiety and resistance to the ventilation. Perform general anesthesia to induce and maintain anesthesia. Corticosteroids, so we have cortisone acetate, and the opioid analgesics have morphine and fentanyl, pain management. Antibiotics are sensitive to the cultured organism. And lastly, for the respiratory failure, we perform intubation to assist with breathing, hopefully to increase the oxygen saturation. We perform mechanical ventilation. Okay, we're not going to go into the second lecture. We're going to stop here.